Yeah, if I forget, you guys remind me each week, just because as I get in the middle of things, I forget. All right, let's jump right into the legal concepts, risk management, and ethical issues of being a surgical technologist. You know what I mean? I'm trying to get this to go away. It may not. Sometimes it does. Let me see if I can get it to hide. There. Okay. All right. So the objectives are, one, to analyze the concepts of law. And just so you know, this PowerPoint would not let me edit it at all. So it is straight as the creators of the book made it, which I don't usually like. So we're going to analyze the concepts of the law. We're going to interpret the legal responsibilities of you as a surgical technologist and other team members. We're going to compare and contrast the criminal and civil liabilities and the consequences for these acts. We're going to analyze the AHA's patient care partnership. I don't remember that part. Describe the need for professional liability insurance policies. And that would be if you're serving as a, probably more only as a travel. Most facilities, we'll cover that, but most facilities do it. Analyze the key elements to relating to developing a surgical conscience. Assess the resources that aid you in interpreting and following professional standards of conduct. Develop an increased sensitivity to the influence of ethics in your professional practice. Analyze the role of morality during ethical decision making. We're going to talk about examples of ethical situations and problems in health professions. Look at the scope of practice issues and how they relate to your position. We're going to look at a lot of risk management issues, prevention, correction, documentation techniques. And then I've consulted with the lab instructors, and they're going to expand on a lot of these topics for you guys Thursday and Tuesday night. So that'll be helpful just to really kind of reiterate how it applies in that setting. Recommended practices and legal elements of proper documentation, which in most cases, that's not going to be a responsibility, but you need to know what it looks like in case it is. Problem solving and ethical decision making, assessing errors in the operating room and devising a plan for investigation, correction, and notification. Now let's jump right into the legal issues. And if you have your book and you want to follow along, feel free. Starting on page 28. So the legal issues, there is, it's really about the keeping in mind that you are there for the patient, that it's really about the standards of care, the agreements that are in place, the guidelines, the state and federal laws. All of these come into play when you're looking at the overall legality of this, of your position in this organization as a whole. So when you're looking at a specific situation, you have to take into consideration all of that. One, your competency level. Two, your job description. Three, the state and federal guidelines around that, as well as just the overall standard of care that is carried out in the OR. But the general intent of healthcare legislation is, we have to always remember that it's the original founders of these standards of care is about patient care. And so that's all reflected in the AHA patient care partnership. So there's a ton of like legal terms, doctrines, and these principles. We'll go over a few of these in the book. If you look at it, I've highlighted a few in the book that I wanted to make sure that I covered, primarily because it could be things that you want to be familiar with. So the first one that I wanted to bring up was affidavit. And so an affidavit is where you volunteer to provide just a statement of facts, sworn to be true before an authority. And so this would take place if there is some kind of wrongful death or wrongful action suit that's in place, and you were in on the case, and they want you to provide an affidavit that's you volunteering. You're volunteering to provide a statement of what happened to the best of your knowledge. And then the next one I want to talk about, it's called iatrogenic injury. And an iatrogenic injury is something that results from the activity of the healthcare providers. So this is really important when we're talking about maintaining your sterile field, because if you compromise your sterile field, and then there is a result that can be linked back to that break in sterile field, then you would be responsible for that iatrogenic injury. Liability is obligation to do or not to do something. So there is corporate liability and personal liability. And so this is just being, it's basically about being accountable. This is your obligation. You're liable to perform in a specific manner. And so just being familiar with that. Malpractice, that's professional misconduct. You do not have to have malpractice insurance. I, however, do. Now, there may be cases where you choose to have malpractice insurance, and that would be up to you, depending on your work status. Let's say you decide you do want to do travel scrub work, then you would look at some of these travel companies, and a lot of them do provide you with malpractice insurance, and others may require you to provide your own. And so this is malpractice is when there has been professional misconduct resulting in harm to another, and that could be to a patient, and that usually consists of an error on the provider's part. Negligence is a form of malpractice, and so this negligence would be just omission, which is not doing something, or commission, which is doing something. So, that could be, there's criminal negligence, which is, that's when it's a reckless disregard for the safety of another. So that's, we see that a lot with negligence of children. Perjury is another one. That's intentionally providing false testimony. And then one that we're going to talk about in detail is tort. And so this is a civil wrong. And that can be intentional or unintentional. We're going to talk about that in greater detail. Okay, we're going to finish this and then go to tort. Under the legal doctrines, the only one that I really want to talk about is Ager Primo, and this is the patient first, and this is the motto of the AST. So really just making sure that you're putting the patient first, because if you think about what your role is and maintaining that sterile field, you're always putting the patient first. You're aggressively maintaining the safety of the patient by maintaining that sterile field. And then over on almost the last is primum non nocere. This is above all, do no harm. As physician, that is our number one tenet. We have to, that is first of all, do no harm. And yours is Ager Primo, which is the patient first. So we're going to talk about torts. And remember, torts are civil wrongs. They're not criminal wrongs. They're civil wrongs. And this is when it's, like it says here, independent of a contract, meaning you're an employee, you're not a contract. So, and when it would have a contract would be something, say, I have a contract with someone to build my house. And if they do not build my house the way I want to, that that term would not be tort, it would be a civil suit, not a tort. And so tort is a civil wrong independent of a contract. And so we're just going to look at intentional and non-intentional of those. Intentional ones would be like assault and battery. And like it says here, willful and violate the civil rights of a patient. Assault and battery is one. Defamation, an example of defamation to a patient would be talking in a derogatory, negative way to the patient or to someone else about the patient. That would be harmful. That damages either their reputation or their good name. And here's a couple of ways that this would be applying to the role of the scrub is, one, if you break HIPAA, we're going to talk about that in a minute, and you tell people what a patient had done, and it was in a negative way, in your opinion, then that could be considered defamation. And you may have heard defamation of character. That's what this is referring to. False imprisonment. That's illegal detention of a person without consent. An example of this in the OR is using restraints, or in the medical field is using restraints. It is illegal to use restraints without consent. And so when we have patients that have to be restrained for their own safety, we have to get the consent of a family member. Because if we do it without consent, then it is considered false imprisonment, and we're liable. So, because we cannot restrain someone. Now, let's see, intentional infliction of emotional distress. So these are remarks that are made to the patient that cause emotional distress, and then invasion of privacy. So that would be, like I talked earlier, disclosing of that private information. Unintentional, and so all of those we just talked about, you had to intend to do those. They're not, oh, I made a mistake and I called them a name, or I told someone that they had liposuction done. You meant to do that. That is not unintentional. Now, these are unintentional. You didn't mean to do these. Patient misidentification is a big one. And like it says here, this is the most common types of patient care errors. Negligence and malpractice can be in these categories as well. Negligence, this is where, you know, there's different ways that you can be negligent that are different than the intentional negligence. So patient misidentification, I think Alex is going to talk some about a lot of these topics tomorrow night in that setting, just to really give you a firsthand feel of like how these things are prevented in the OR setting, and they've become a part of the normal OR routine. Try to reduce the events that used to occur, because a lot of this used to occur a lot, and so, you know, it's a little bit more well known, and so now they're really working to create systems like timeout and such that will eliminate all these. So patient misidentification, so that's why they check and cross-check who it is. And then, hang on a minute, let me see. There we go. Performing incorrect procedures. If you've been on any procedures in the past, or you've seen it even on TV, at this point, surgeons must write on the site. They have to mark it with an X usually, and their initials to make sure that, an example, you know, I had rotator cuff surgery done last year, and the doctor had to write on my shoulder. He made a big X on it, and he put his initials on there. And so every doctor has to do that to make sure, because in the past they were operating on the wrong side. You know, they might have you know, if I had woken up and they had operated on my right rotator cuff and they hadn't fixed my left, that would have been a lawsuit. And that's what was happening. There was a lot of lawsuits occurring because the wrong site was being, there was a wrong procedure done on the wrong site. So this is where you're going to take extra precaution to make sure that the site is identified, patient's identified, the site is identified for it, and that's all part of your timeout now. Okay, we're in the timeout. You're identifying the patient, it's checked and double checked. You're identifying the surgical site, it's checked and double checked, multiple eyes on it, multiple checks. And then next is your count. Foreign bodies used to be left in bodies all the time. This happened so many times. I knew people personally that this happened to. There would be infections, couldn't figure it out. Went in, there was one sponge. So foreign bodies left in patients, secondary, like incorrect sponge count, sharps, instruments. So that's where it's really important to make sure you're counting and that you have a second set of eyes. And that is why when you're counting, you're laying those sponges out. You're not just flipping through them. That is why you have to lay them out so that there's an exact count and two sets of eyes are seeing that count to eliminate this. Patient burns. So this could be from heat, you know, so it could be from the bovie, it could be from instruments that are still hot, you know, out of the autoclave. It could be a electrical device that's being used in the OR that did not get properly grounded. That could cause a burn. I mean, thinking about a lot of the sparks that are flying in the OR, there's oxygen being used. There's a lot of combustible opportunities. Improper use of lasers could cause burns. And prep solutions are flammable. So that's one reason that when you're participating in the preps, the skin prep, you have to make sure that there's not a collection of those prep solutions on the floor or anywhere that could cause a hazard as far as a flammable situation. Anesthesia gases are flammable. So it's just important to always make sure that you're keeping all of the flammable things that are in your control reduced. Irrigation fluid that's too hot could cause burns as well. The next one, falls or positioning errors. And as you guys get into positioning again, you'll see that there can be some errors that take place, especially if you guys practice with each other. You can see there's some positions on that OR table that are very uncomfortable. They've started using a lot of bean bags now so that they're able to air inflate and keep the patient a lot more comfortable. Patients that are left unattended on the table can fall because once they get on the OR table, there's no sides that, a stretcher, it has sides that, are up for the patient's safety. But once they're on the OR table, there's no rails. And so that's why usually the patient is already sedated, but they're also strapped to the table for that safety reason. And staff is close by at all times. So just keep that in mind. So a safety strap should be applied as soon as the patient is moved to the OR table to prevent that fall. And then, like I said, positioning errors, they've gotten much better at positioning now because there was so many positioning errors that would have, joints could be very irritated or even injured at times because of incorrect positioning. Because thinking about someone, let's take an elderly patient, you got a geriatric patient, they have severe osteoarthritis, and let's say they have it in their shoulders, and we're doing a surgery on a right kidney. So they're on their left side for 3 hours. Well, guess what that's going to do to that left shoulder if they're not positioned and highly, highly cushioned. And so these patients now, you'll see it looks like they're wrapped in bubble wrap on the OR table. They're very cushioned. There's a lot of support for every joint. You want to make sure that there's no pressure points on the joint. Okay. And then improper handling, identification, or loss of specimens. So this is one thing that they're going to cover in the lab is about proper labeling of specimens, how to handle them, how to handle a situation if it's misplaced, what to do in that situation. I want you to go to the lab with a lot of questions on these of like, how do I label them, a lab specimen? What all do I put on the label for identification? How do I handle it? Who do I give it to? Ask a lot of those questions, get some good feedback because they work at different facilities. So it'd be really nice to hear how different facilities handle those procedures. And read this chapter, especially that section before tomorrow night. Okay, and then the next one is about, let's see, that did not go where I wanted it to. Okay, and the next one, they don't have it on the slide, is incorrect drugs or incorrect administration. And so this is really important because you as scrubs, you're going to be responsible for making sure the right medication is on your back table and ready for the doctor. With your circulator, you will double check that a couple times so you will know exactly that you've got the right thing that was ordered. And then with the administration, that is making sure that that you have everything that you need to provide the physician with that drawn up and the right administration tool, whether it's a syringe with a needle, or if he's like injecting it right into the site, or if it's going down an ET tube, or if it's going in a bile duct or whatever. So just making sure that you've got all that ready. And then harm secondary to the use of defective equipment. And we talk about that a little bit later when we talk about medical devices. But when you get into like orthopedics, you'll look at saws, drills, reamers, different things that are electrical. And before a procedure begins, you will be playing a role in testing those devices and making sure that they're working properly. Because if they're not, then you want to get them replaced before the procedure gets underway. If during the procedure that a medical device is found to be malfunctioning or just not functioning at all, then you can get circulator to replace that. It is a little more timely to do it in the middle, so you definitely want to make sure that it's tested prior. Because you want to make sure that there's no harm to the patient, because that is a defective piece of equipment. Loss of or damage to the patient's property, and that's not usually going to be something you deal with unless you're working at a really small facility and you're kind of acting as all roles except the surgeon. So if you're acting as the circulating nurse and the scrub and then the post-op nurse, then it is going to be your responsibility to make sure that the patient's personal belongings are in a secure location. This is really important. Harm secondary to a major break in sterile technique. So remember, that's that iatrogenic injury we talked about. So you want to make sure that you have a really strong practice of sterile technique and a strong sterile conscience to make sure that you're maintaining that. Okay, and then we're going to move on to the consent for surgery. This is really important. This is also covered in that timeout, making sure that there is written permission on the chart and it's visible. Most physicians require to see that, to actually put eyes on that. I know that when I get consent with every patient, and I get written and verbal consent from the patient. So I actually put my eyes on that consent form, and then I'm doing a lot of telemed, I get them on the phone, and I want to make sure they consent to this visit. And it's on the chart. So you may know that it's on the chart, but the surgeon will want to see that consent majority of the time. And so proper consent, this is where the patient grants permission to someone that has the capability and the authority to perform the procedure, or they have granted someone else permission to do so. And so that may be where patient is incapacitated or like elderly, most of you have a situation similar where my parents, as they aged, they assigned one of the children to be their person who could provide that consent in their stay. So now proper consent also presumes that two individuals are involved. And so that is the recipient and the person performing the action. And it can be expressed or implied, meaning it can be written or it can be verbal as well. So informed consent. So this is making sure that the patient is aware of what is going on. They know the proposed intervention, they know the risks that are involved and all the variables that can happen. The surgeon is responsible for making sure that the patient is aware of all of this, and or the family that is making the decisions. So just saying, here's what's going on, here's what we can do, here's what could happen, and here's all the things that are involved in this. So the surgeon is responsible for making sure that written consent, informed consent is secure. So that is where they won't move forward without informed consent most of the time. Well, if they want to maintain their license. The information has to be understandable. So you can't go out, they can't go out to a family and say, and talk completely in medical terms. They, you know, they have to make it understandable. They have to talk in layman's term, explain it in a way that the family understands what's, or the patient understands what's really happening. And there can't be any coercion, there can't be any intimidation. It has to be the patient's choice. Now, there is a lot of that still happens, but it is not meant to happen. And then, of course, the surgical procedure or treatment has to be explained, and the risk, benefits, complications. If there's any alternative therapy available, and their risk and benefits also have to be explained. This is all in informed consent. On the informed consent form, I think this is a sample. This is a sample of a standard consent on page 33. But on that, it has to have the patient's legal name, the surgeon's name, the procedure that's going to be performed, and it has to include which side, left or right, if that's applicable. If there's and the risk of anesthesia and the procedure, including any complications. And I'm pretty sure that almost every surgical procedure has, you know, it will say complications could be this, and including it could lead to death, you know, because that had to be included because there were lawsuits that came about that said, you didn't tell us we could die from that, you know, that my family member could die from that. Well, now they tell everybody, we're going in for some liposuction and you could die from that, you know, because, I mean, don't say it that way, but, you know, they have to make sure that that's covered and everything. Patient's legal signature, there has to be witness's signature on there, date and time of all the signatures. So those are all the provisions of an informed consent. So the patient has to be of legal age or a legally emancipated minor, have to be mentally alert, or else someone else has to sign for them. They have to be legally competent and cannot be under the influence of drugs or alcohol. And then this does have to be signed before they go into the surgery or treatment area. Now this can be done either by phone, and when this is done by phone would be, let's say my mom is in Alabama right now, I'm here in Washington. If something happened and I was the one that needed to give that informed consent, the doctor could get on the phone with me and explain the procedure, explain the risk, explain all the variables, everything that we just talked about, and then ask for my consent. I could give my consent over the phone and he could move forward with that. Electronically, like at our clinic here, we do a lot of DocuSign informed consent, and then administrative, you could actually physically sign the document. Or it could be an agreement of two consenting physicians. Implied consent is never the preferred option, only an emergency situation. And that situation would look like, I was in a car crash, no one was with me, I needed immediate surgery, I needed emergency surgery to maintain life or limb. They would imply that I'd given them consent and they would go ahead. And of course, patients have the right to change their mind and withdraw at any time. And that usually is called AMA, against medical advice, when that happens. Documentation. Now, in most of the settings that you guys are probably going to look at, you will not be responsible for documentation, but it is Of course, it's good to be familiar with it all, just so that you are well-rounded in your training and you know the general basics of a documentation. So this is what you'll be calling the patient's chart. And so it consists of the first, the identification of the patient, the physician, nurses, other healthcare providers. It'll have their medical history in there. It'll have record of the initial physical exam. It'll have all the diagnostic results in there, whether that be labs, imaging reports. That's about all I can think of with the diagnostics. Anything else that might have been performed in there. Treatment plan. Everyone that has seen them while they're in the facility is going to be in the chart, the details and the results. So all the findings that are found during the hospital stay will be in that chart. Now on page 35 in box 2-1, there is a do not use abbreviation list. This was provided by the Joint Commission, and this came about in 2004. I'll never forget this. You know, we'd been charting the same way for so many years, and then Joint Commission came out and said, these are a bunch of terms you can no longer use in your chart. And so, like, you know, there's a lot of medications that are in IUs. Well, you can't use IUs anymore. You have to write out international unit. QD used to be Q, it would mean every day, and now you have to write daily. And you can just see on down through there, you know, you have to, in the past, mLs and cc's were interchangeable. They eliminated that. We can no longer write cc's, we have to write mLs, because that is a legitimate metric measurement. I think that was all. Any questions on anything so far? Okay, now we're talking about incident reports or sentinel events. So this is anytime that anything has occurred in the hospital that needs an incident report, whether it be a fall of you or the patient, any staff member or patient, medication errors, any burns that we talked about during the procedure, loss of specimens. So all of those things that we just talked about that were those unintentional torts, they result in an incident report or a sentinel event. And so this is where the risk management department of the hospital, they're really trying to collect data, trying to create systems. And a lot of your systems that you're going to see are already in place are due to past incident reports that risk management put together, and we're like, they're seeing a pattern. And so we're going to create a system to try to prevent future events like this occurring. And they're usually very successful. So that's basically what a sentinel event or incident report is about. Now, advanced directive, this is what we were talking about earlier, that if it's a set of written instructions that address the right of an incapacitated patient to self-determination. And so what that means is if I have an advanced directive, that means I have someone assigned to speak for me if I'm unable to speak for myself. That's what advanced directive means. So you'll hear every patient is asked, do you have an advanced directive? Yes or no. If they're not, they're encouraged to have one at that time. So, and then the AHA patient care partnership. So this came into effect when, what year was this? 72. This was about patients' Bill of Rights. So it allowed patients to have rights and responsibilities. Before this, it was more of I'm your doctor. You need to do what I say. No, you can't have your medical records, all of that. Now it's really backed up. So, you know, the 6 expectations are high quality hospital care, a clean and safe environment, involvement in patient's care, protection of patient privacy, and then help when leaving the hospital to, you know, to help prepare the patient and the family both. Let me see, I don't think it's on here. No. As well as help with bill and insurance claims. So this really kind of shifted the care of patients and the rights that they knew they had. You know, here we're saying, and then in 1990 was the Patient Self-Determination Act of 1990, where it kind of upgraded it just a little bit, made it a little bit better to understand. And you know, this is something just as you as a person, I want you to always consider when you're working with a physician, you're the consumer. And you need to shop around because every doctor is not the same. They're not all they're not all equally trained and competent, just like every other field. Okay, so just like all the scrubs that I've worked with, there's some that are phenomenal and some that are not. And doctors, there's some that are phenomenal, some that are not. So as you are working to find the right physician for you and your family, keep that in mind. You know, patients are humans. They're not ever perfect. No one is. Shop around. And if anything doesn't feel right to you, move on to someone else. Get a second and third opinion. And make sure that you're getting the best care because it is your right. And an example of this in the book today, I took a picture and sent it to my brother because this is an example where Patient Bill of Rights is going to be definitely on his side. He was born with a congenital heart defect and he had that repaired. And he does have some residual heart issues, but nothing massive. And he applied for insurance last year from a company through his work. He works for the government, and then they had offered him a different plan, and it was a much better plan. And so he applied for it, and they denied him, said he had congestive heart failure on his chart. The boys never had congestive heart failure, but some physician had either dictated and the medical coder somewhere along the line in his chart, the wrong diagnosis got put in his chart. So I'm sending him today out of the book. I'm like, dude, use this and fight this and get this taken off. And so he has, by the Patient's Bill of Rights and the AHA partnership, he has the right to fight and get that removed because we have the right to what is on our patient chart. And here's something that I do that I've never seen it done. When I'm done, I've used paper charts. And when I'm done, I offer it to the patient. I say, do you want to look over your chart before you leave? And they always say no, because me offering that, they know that I'm not putting anything in there I don't want them to see. Does that make sense? Have you ever been to the doctor where you try to look at your chart and they turn the computer? I've had them do that. And I'm like, that's my chart. You're writing about me. I have the right to see my chart. And I'm telling you guys this because you will have patients that you may hear them say this, and you may hear staff kind of defend a little bit of like, you can't look at your chart. It's my chart. And so just know that you as a patient have a right to a lot of things, including your chart and everything that's in it, and getting that corrected, as well as adequate care. And so as a scrub, you have the right to making sure that if you're responsible for the patient's chart, it is accurate to the very best of your knowledge, and make sure that what you're putting in there, excuse me, is true, because it does affect them. Okay, that's all on that note. Risk management. Okay, risk management and liability. So these risk management department is the only way I'll say it, but it's kind of a broader than that. They are really in the business of making sure that potential liabilities are prevented and controlled. So they're wanting to really minimize all the risk. They're looking at, as it says here, avoid and control financial loss. And like I talked about earlier, they're looking to identify causes of accidents so that they can create systems to prevent it. An example of that, you get on the elevator and it has a sign in the floor, wet floor. Careful, wet floor. Why do you think those signs are there? You walk in a restaurant and it, you know, and there's one of those little A-shaped signs, bright neon yellow, says wet floor, caution, wet floor. That's there for risk management because that was determined to be a system that worked well to prevent falls due to a wet floor. Same thing happens if there is a consistent accident that's occurring. Risk management department in hospitals are going to take all that data and they're going to create a system to try to prevent those incidents from happening. Issues that impact management policies, staffing, thinking about right now, everybody's understaffed, right? So does that raise the risk of incidents? Yes. Does it raise the risk of negligence? Yeah. Does it raise the risk of errors in the OR? Absolutely. Because you're working under a little more pressure and stress. And so it causes your ability to perform at that highest level to drop a little bit. So you may make more errors. You may slip and fall. You may, you know, because of that stress is a distractor. And so that is a big thing. Employee rights is another one. You know, it's about making sure that these policies are in place to protect the employee rights as well as the patient. So these are some things that impact those policies. Medical errors. This slide was not complete. So it says more people die annually from medical errors than from car accidents. Not only car accidents, because I read the chapter today, not only car accidents, but also car accidents, AIDS, and breast cancer combined. So more people die from medical errors than from all three of those combined. So I think that, if I remember, it made it like the it made it like number 8 on the list of cause of death. So medical errors are huge. Technology has definitely been the best solution for this. I hate how we call it best weapon. It has been a really great solution because now everything is got a barcode. So, you know, circulators now have a scanner in their little pocket, and they pull that scanner out and they scan the barcode on the wristband of the patient, and the chart has a barcode on it, the medication has a barcode on it, the devices have barcodes on it, everything has barcodes on it. So everything is a lot more systematic. So it really cuts down on that. Let me see. Oh, back up. So there's also now, like you see here, it says computer drug order entry systems. I remember about 20 years ago when the first one of those appeared in the hospital I worked at. It was called a Pyxis. And they may still be in the workplace. I've not been in that setting in a while, but they were the first computer basically pharmacy. So all of the medications were kept in this huge cabinet that was a computer, and you had to type in the patient's number and what you were getting and how much, and it would dispense it out to you. And that reduced medication errors because then it's only that, and that is set by the pharmacist. So the pharmacy staff is loading that and how much the patient's supposed to get. And so it really kind of helps control medication errors, as well as it provides security for the nurses that are pulling that medication, that they are pulling the right medication. All right, and then let me see, there was something. Oh, so I want to talk about on page 37, box 2.2. It's talking about the neutral zone. And I'll let Alex know that you guys were going over we're talking about the neutral zone tonight, so that tomorrow night and then on Tuesday night, they can cover neutral zone with you. So the neutral zone is that space in the OR that helps reduce incidents of sharps, a sharps incident. And so it is a neutral zone where there's not hands and needles and scalpels in the same facility, I mean, in the same vicinity. So you're not handing the scalpel to the physician, you're putting it in the neutral zone and they're removing it from the neutral zone. And they'll go over that with you guys, but it is a placement for those sharps to be placed. Your hands and the surgeon's hands are not allowed in there at the same time. So they will place the sharp in the neutral zone and then you will remove it from the neutral zone, or vice versa. So it is also, it's another way, like the Pyxis, to eliminate sharps incidents, where the computer drug ordering system is a way to reduce medical errors. So it's another systematic way to kind of help reduce that error. And then talking about, and then it continues over on page 38 as well. And then there's some additional techniques to provide some sharps safety. The Safe Medical Device Act. So this was where the FDA expanded to regulate medical devices. This was had a big impact on the OR and on the medical device industry as a whole, because it allowed that regulation of the medical devices to ensure the safety. And so this requires the hospitals and the distributors to work together in a tracking method. And a perfect example of this is pacemakers. So one, pacemakers have to be tested to make sure that they're working accurately before they're placed in a patient. Once they're placed in a patient, that patient is giving a tracking card that they keep in their wallet, and it shows everything, serial number, everything about that particular device that is placed inside of them, okay? So then they are always able to show what device is placed in them. So an example, my dad had a pacemaker for years, and you know, the battery's not supposed to, it's supposed to last like 5 years. And after about 3 years, something started malfunctioning with his pacemaker. He went in, they checked it. It was beginning to malfunction, that particular device. So they had to remove it and replace it. So he had always had to carry that card that would enable them to track which device he had. That is one of these, that's an example of what this is about, okay? John, do you work in the medical device industry? No, okay.
No, pharmaceuticals, so
okay.
Injectable stuff.
Okay, I was thinking it was that or medical device.
Well,
okay.
We have, like, empty vials that they consider devices, but I don't know, it's weird.
They consider empty vials medical devices?
Yeah, because maybe not. I forgot, but we do like these sterile evacuated vials, and physicians can use those to like sterilely mix.
Yeah.
applications. So that I guess, yeah, they consider it a device.
Yeah, that makes sense to me.
Yeah.
Okay. And this act also requires the medical device users. So like when that happened with a pacemaker, then the patient is required to report that incident. So that would help, like, because that way you're not saying, I had an adverse reaction to it. It actually was the device. It wasn't something that was going on with my body. It was the device that caused that to happen in my body. All right. And then also managing patient employee injuries. Anytime, and this is really important as an employee, anytime that you're injured, you report it immediately. Even if you're like, I was in the locker room and I slipped and I fell and I'm embarrassed. So what? Report it. Because what if tomorrow you wake up and you can't walk, your back is injured. So you injured something and you didn't report it. Well, it's easier to move forward with that if you reported it immediately. And then in that case, medical treatment can be rendered immediately for you. It's documented. That provides that legal documentation if it's needed later. An example, I don't remember, I want to say now 25 years ago or so. I'm trying to think how old I was. AIDS was really raging, and I was stuck with a needle in the ER by an AIDS patient. I reported it immediately. I had the first dose of medicine within 45 minutes. And I say this because immediate report, and I didn't want to report it. I did not want to report it. And I'm in the clean room scrubbing the site, and the nurse manager walked in and was like, what's going on? And I reported it. I mean, I was intending to report it, but I didn't want to report it right away. I was trying to like get my wits about me. So I'm saying to you, once you have an injury of any kind, if you're like, did that go through my glove? Did that sharp go all the way through my glove? Did that needle go through my glove? And then when you pull that glove off and there's blood, it's an incident report right then. Okay, right then, it's immediately reported. You get circulator and say, I've been stuck, and then there will be a procedure that you'll go through from there. So make sure that you're following this rule because it's really important, because you want to make sure that you are protected. Okay. I didn't know the patient that I got stuck by was HIV positive or that had full-blown AIDS. I suspected it, but I didn't know it for sure. And honestly, I was more worried about HEP than I was AIDS at that time. But I'm just saying that reporting immediately, getting on the treatment as soon as possible is highly important. Malpractice insurance, we covered this a little bit. It is typically covered by the facility. But now if you professional liability insurance, if you're working outside of a facility that's covering you, you definitely do want to get that. You can look at your association, your national associations. A lot of them will have links to liability insurance because they have worked out a partnership. So you get the best deals most of the time going through those companies to get your insurance. And don't ever not get insurance because you're like, it's too expensive. Believe me, it's cheaper than a lawsuit. HIPAA, let's talk about HIPAA real quick. And it's spelled with 2 A's, not 2 P's. So it is the Health Insurance Portability and Accountability Act. This provides privacy standards to patients with their records. And so this is very protective of the patient and their health-related information, their private information and their health-related information. So You know, because this is why you no longer have to give your social security number all the time. You know, HIPAA was definitely established to protect health records, but it kind of started the ball rolling of not providing your personal information all the time. So this allows you to also, this works in with the patient's rights, where you get easier access to your medical records. I have to get medical records from all my patients that I see on a daily basis, and you have easy access to it. And because of this, HIPAA requires that. HIPAA is also where it applies when you're talking about, I think we've talked about this, like you had a case, and then let's say Yolanda and Tawny were in on a case together, and this was the most interesting case they had ever seen. They get on the elevator, they're going down the elevator to lunch, and they're just talking about it. They're so excited about that. But it had some information in there that could be identifiable. And in that stuffed elevator, there was the family. And they're just jabbering away about this patient. Wow, could you believe the size of that? Guess what? The patient's family knows what you're talking about. They can have your job. And they can sue the hospital $10,000 for every incident of HIPAA violation. And what they'll do is it will open up a big can of worms, and it will get your hospital audited by Medicare. So they do not want that. No hospital or facility wants audited by Medicare and Medicaid, because then they'll pull every chart, and then they will fine them. I think it is about $10,000 for every incident in every chart. And so you do not want to be the cause of that, because guess what? You won't have a job after that. So you never want to talk about a case outside of your OR, okay? Can you talk about it in the locker room? Yeah, you're with the people that did the case with you. You can talk about, because if you're talking about it in a situation where you're learning from each other, absolutely. But remember, this is the patient's private information, so you do want to be respectful and protect that. Okay, where are we at? 9:05, GB alone. And it also allows the patient to file complaints, and also prohibition from marketing. So they can't like take a picture of my procedure and post it in their marketing. So that's no longer allowed. Did they used to do that? Yeah. We used to take pictures of our patients and have them on our phone before this. So that's crazy, huh? I still do, but it's their feet. Nobody knows them. I have permission. So, I have to show you guys that sometime. So I used to do this treatment on my patients, and I could see the result. And I wasn't operating on their feet, but I'd see the result in their feet right away. It just kind of showed me what was going on in the rest of the body. Ethics. Let me see. Hang on, this picture got moved. This is where we're talking about here. This is where what's good for the individual. Yeah, and I'll let you read through this. So this is talking about ethical and moral issues. So when you're talking about ethical issues, this is about making sure that you do things that are good for the individual and for the society. You just, looking at if something is ethically or morally wrong or right, there is a line in here where it can tend to feel blurred, but it's, ethically there is a right or wrong, definitely. And then morally, this is about a code of conduct and a guide to behavior. Let me look and see. I think there's a whole section on this. Yeah, starting on page 39. it's talking about having personal values and really about being accountable for your actions, being responsible for your actions. And then it goes on to talk about some different viewpoints. There's going to be a lot of different viewpoints in certain areas, such as like animal experimentation, assisted suicide, care of individuals with HIV and AIDS, elective abortion, elective sterilization, gender reassignment, genetic engineering, Good Samaritan law, human experimentation, on and on and on and on. So there's a lot of topics that you will be exposed to, and you're going to get a lot of different viewpoints on these. And so I would say that it is important to, one, kind of know where you stand, but it doesn't mean that you have to engage in these conversations, especially when you're in the role of a case. You're working in a case. This is not the time to get into something that you feel emotionally charged by. So you do want to spend some time thinking about where you stand on certain things so that you're not caught off guard. But at the same time, be open to honoring and respecting other people's opinion, especially if it's different than yours. Okay. We could debate all day on abortion. We could. I could assign 2 teams and say, you debate for it, you debate against it. But it doesn't matter, because everybody is going to be able to have their own viewpoint. Everybody is. Where you think anything is right or wrong, everybody is allowed their viewpoint. So what I'm saying is, know what your viewpoint is, but also know that everyone is entitled to their own, and you've got to be very respectful for that. You don't ever want the OR to be a place that comes out in a conversation that you feel like you're having to defend your viewpoint. And I will go ahead and say that if you're ever in a situation where you're requested to reveal your viewpoint on something, I want you to consider having a response that is similar to, I'm just not really comfortable discussing it in this setting. I want to keep my focus on the patient. I'll tell you, it doesn't matter how high and mighty a surgeon is. If you respond with that, you will shut them down. Because there's some cocky docs out there that want to get something going. But if you respond to, this is just not a comfortable setting for me to have that discussion. I really just want to stay focused on the patient right now. Make it only about you and your desires. Does that make sense to you guys? Because you're going to get, OR is a chatty place. It is. And you want to make sure that you're prepared for that type of setting, so that when you're in that you already have a kind of a preset way out. So you don't have to come up with your defense statement right then. You don't have to figure out, gosh, what do I say to this doctor right now? This is not a comfortable setting for me to discuss my viewpoint on that. I'm just going to stay focused on the patient right now. Does that make sense? Does that feel true for everybody? Read through this on your own time and get a better feel for it. Here's some more examples of moral principles. Impartiality, objectivity, duty of care, confidentiality, full closure, on and on. What makes a right act right? To whom is moral duty owed? What kinds of acts are right? These are some decision-making components. What's the relationship between specific situations and ethical principles? What action is it to be taken in the situation at hand? You know, because your personal values, your accountability for your actions, your religious beliefs, your cultural beliefs, all of that's going to come into play in your decision making of your ethical values, the corporate integrity, and then how you problem solve through that. Professional code of conduct. Every profession has a code of conduct. The AST has established a code of conduct, and that does provide those guidelines for the scrubs. Scope of practice. So this is going to be different in every state. I know that we were talking last night about how some states allow scrubs to be first assist, other states do not. Your scope of practice is gonna, like I know in the South, I have a friend who is a scrub, and in his training program, he was trained how to close a procedure, and he was in Alabama. Alabama scrubs are not allowed to close, and where I'm from in Alabama, we're on the Alabama-Tennessee line. And in Tennessee, scrubs could close. So guess what? He got a job across the state line in Tennessee so he could close. So it's really about looking at the state scopes of practice, because you may want to do what's in the more advanced state of scope of practice. So you may be on the Washington-Idaho line and you're like, or you may be in Idaho, but you like the scope of practice in Washington better. And so that helps you determine where you want to work based on what the scope of practice is. And so there are federal agencies that set kind of the broad scope of practice. So when the AST was created, then there was like a national or federal scope of practice. So here's what scrubs can do, but then each state can expand upon that and broaden that out. There's also, like I said, state law and regulations, but then hospital policy and professional organizations. So hospitals may say, our scrubs can do this. You know, they cannot expand beyond the state laws, but they can constrict, you know, so they may say our scrubs can only do this. So professional organizations, the same thing. And then credentialing. I want you all to make a commitment to yourself that you will become credentialed at all costs, meaning if you get offered an amazing job right out of school, have a stipulation. Like I've had 2 students in the last 6 months or so, this happened where they're like, I've got this job offer, but I really want to finish my certification. And so we worked it out. They made that part of their hiring stipulation, is that I have to complete this to get certified so that I can, it allows you to really continue to develop in your career, and it doesn't limit you, because you're getting all the training and you're going to get all the clinical experience to be certified. So all you have is the certification exam, and that's basically your final exam from the program. So it is highly, highly recommended that you finish your cases to get the certification done, because then that allows you to broaden your opportunities. I'll say this as well, that certification is a renewable thing. So make sure you keep it renewed. If you allow it to lapse, like I know the Sacred Heart doesn't require it, but who says you'll work at Sacred Heart the rest of your life? And I will tell you this, some states require you to retake the exam if you're lapsed for X amount of time. So, and I know in medicine, and all states are different. An example, of licensure, Oregon, like I wanted to take my, I was licensed in Oregon and then I moved here and I got licensed in Washington. And so I wanted to take my medical license in Oregon down to, I wanted to close it out. Well, they let me know if I ever wanted to be reinstated, I had to take the medical board again, the exam. I said, never mind. Here's my money. Keep me going. I'm like, I do not, because that you don't want to take your board exam again just to be licensed in a state. So keep everything upgraded, keep everything updated once you're certified. And so there's different types of this credentialing. There's some places that you just need to be registered with the state. And I know that as a student, you can be registered with the state of Washington as a surgical technologist. And I'm pretty certain that every job requires you to be registered as a surgical technologist to be hired. And then once you pass the exam, once you have completed all of your academics and all your clinical hours, and have fulfilled your 320 hours and I already said that, and your cases, then you apply for the certification. Licensure is going to be state by state. I don't think the state of Washington requires a license at this point. I think the certification is the registration, and the registration is the extent of it in my understanding in Washington. If you guys know any different, that would be helpful. But the certification, it's not a requirement, but it is definitely a bonus. Got it? Commit to it, commit to it. And then also, one thing that's really important about the core curriculum for sure is protecting the public, because that makes sure that the educational programs are providing the personnel that has the quality education that is required for that competency level. I will say at this point, we are not an accredited school, but we're accepted by the state is all I remember, because they come in and they do all of their examinations and stuff. So, and the programs are based on that core curriculum for surgical technology. Okay, any questions on any of this? Because so far we have reviewed concepts of law, legal responsibilities, criminal and civil liabilities, insurance policies, ethics, scope of practice, problem solving in an ethical way, and that would be all. All right, questions? You guys are full of questions.
Can you be employed while getting your case hours and cases?
Yeah. Yeah, so what you can do is you can get like the bulk of them, and then you can complete them. You have 2 years to complete them after graduating. But I will tell you, most facilities want you to be really close to done, or they want you to be done. I'm not seeing any yet that hired someone and said, oh, no problem, come on, we'll let you finish here. I had to like send in verification that they were like 95% done. And this was Providence in the last few months. So they definitely will allow you to finish. An example of this, one of our students was doing her rotation at Valley, and Sacred Heart wanted her in cardiology. And so we had to push to get her all of her generals and ortho and all of that done at Valley, because they're like, we want her now. and she can get all of her cardio ones done here because she can get those 55 done there. But we had to get her transcript sent in, and I had to provide verification that she had done everything except that, and the date that she was going to set for her NCCT. So yes, they can hire you before that. And then, like I said, you finish those in the last couple of years, and I mean in the next 2 years. And then I had one today. I was working with a student who is being offered a position at Deaconess, and she was short 10 hours in her rotation. I don't think she realized it because she completed her rotation. And then as she sat adding it all up, she texted me and she was like, I'm 10 hours short. What do I do? She's like, can I finish it on the job? I'm like, yeah. As soon as you have 10 hours on the job, get somebody to sign that and shoot it to me. And because that's all she likes, to be certified. She's passed her exam. She's got all of her cases. She just needed 10 hours. So she'll get first 10 hours on the job. She'll be done. We'll get her paperwork filled out and sent in. Or I'll sign it and she sends it in. So good question though. All right, any other questions? Becky, your household okay? Good. All right. Anything to add? Let's see what we got.
Ginger ale and crackers, just keep them on. Just keep
Ginger
them
ale and
on.
crackers. That's it. That's it. I will tell you guys, there is a over-the-counter natural homeopathic that is, I make everybody I know put this in their first aid kit. It's called Nux Vomica. Guess what it's for? What does it sound like? Yeah. So it's the little homeopathic pellets. Whew, it'll get rid of that. So when we are feeling what we call it pukey, we take those little pellets, like 3 of them, like every 15 minutes. After about an hour or 2, it's gone. So quite amazing stuff. I know we're packing, so I'm creating a moving first aid kit, and I've got like 4 bottles of Nux Vomica in there, 3 bottles of Arnica. You know, I'm like, I'm not running out, because there's nothing worse than being sick and all your stuff is packed away and you got to try to find a Whole Food somewhere along the way. So, yeah, Nux Vomica. It's very good for you. All right, good questions. Appreciate all of you guys working on the cases together and doing good in your breakout rooms. If you guys don't have any questions for me, we're not going to watch a video tonight because we're at 9:30. I know you guys were like, oh, now there's a video coming. No video tonight. So I know they're lots of fun, aren't they? I have to tell you guys, I've Googled every one of those people on those videos. I'm like, where are they from? You know, I'm like, I think they're like Amish or something. I don't know. I just am like trying to figure out where these people are from. So, and I can't, so I give up. All right. Darby, I will have the exam ready for you tomorrow, and I'll look at that question on the DO and make that correct. So it will adjust your scores a little bit. Okay. All right. Good night, everybody. Go get some sleep. I'll see you guys
Thank you.
next week. You're welcome. Thank you all.
Thank you.
Bye.